Okay, so let's continue with our rest of the topic. Here it is. So see, uh, azole again, after amphotericin B, it is a broad spectrum group of drugs, covers most of the fungal infection. It may be static, it may be sidal in nature depending on the drug. And the most important thing is the most commonly used antifungal agents are from azole group. Now you can see the structure of azole where X can be C and X can be N. If X is C, then there are only two N in the structure. We call it imidazole. But if X is N, in place of X, if there is nitrogen, then we call it triazole because there are three nitrogen in the structure. Simple. That's why we divide it into two groups, imidazole and triazole. So two nitrogen in structure, imidazole. For topical use, there are these drugs you can see: iconazole, miconazole, clotrimazole, and ketoconazole. Remember, this word clotrimazole is different, and the word cotrimoxazole, which we are reading so far as antibacterial agent, is different. Do not get confused with these two terms. Cotrimoxazole is combination of trimethoprim and sulfamethoxazole, which is an antibacterial drug. Clotrimazole is a azole antifungal agent, which is used for topical fungal infection as topical cream ointment. Then systemic fungal infection के लिए we can use ketoconazole, and there are newer entry into this group like butaconazole, oxyconazole, sulconazole. Just to remember the name. So most important is ketoconazole. Then comes three nitrogen in the structure. We call it triazole, and all those drugs which you already heard like fluconazole, which is the most commonly used antifungal agents nowadays. Apart from it, itraconazole, which is used in histoplasmosis, voriconazole, posaconazole. Posaconazole, as I told you, apart from amphotericin, the only other antifungal agent which is useful in treatment of mucormycosis is posaconazole. Then there is some one more drug, that is terconazole, which is topically used for superficial infection, only topically used. So both these groups, triazole, imidazole, or as a whole, azole group, are structurally related compounds. The mechanism of action is same, and they are having similar antifungal spectrum. Here comes the mechanism of action as ergosterol biosynthesis inhibitor, not amphotericin B. Amphotericin B is not a ergosterol synthesis inhibitor. So there are the steps: squalene. Then there is an enzyme squalene epoxidase which convert to lanosterol. Lanosterol converted to ergosterol by the enzyme pol alpha demethylase. Here azole are acting, and is this step terbinafine is acting. So there are two groups which are ergosterol synthesis inhibitor, azole group and terbinafine, acting at various enzyme and various step of ergosterol biosynthesis. The final step of ergosterol biosynthesis is lanosterol to ergosterol conversion by demethylase, which is blocked by azole, while a step prior to this step is conversion of squalene to lanosterol, and this squalene is synthesized by the enzyme squalene epoxidase, which is blocked by terbinafine. We'll see that when we see the terbinafine. So don't get confused with this term ergol biosynthesis inhibitors. Amphotericin is not a ergosterol synthesis inhibitor. So here this is the site of action, azole as well as terbinafine. We see terbinafine here as well. So there are some drugs like miconazole, clotrimazole. Let's talk about them first. That topically they can be used, and the indication are dermatophyte infection. You need to read it from microbiology that what are various dermatophyte infections like tyrises, versicolor, typical presentation, then tinea cruris, corporis, capitis. Depending on the which body part tinea is infecting, these are like tinea cruris is body, corporis is body, cruris genital area, capitis is scalp, candida, oral, pharyngeal, vaginal, cutaneous, any candida, they are very useful. Topical agents like miconazole, clotrimazole. Adverse event are root associated adverse event, like whenever you use by topical root, the local irritation, itching, burning can happen at the point of application. And miconazole shows higher incidence of vaginal irritation and pelvic cramps as compared to clotrimazole when used for vaginitis. Come to the very important drug of imidazole group, that is ketoconazole. It is the first orally effective broad spectrum antifungal agents. Before that, all the like amphotericin, are parental agents. So first drug which entered into the classification as a broad spectrum antifungal as well as orally effective is ketoconazole, and it is effective against both systemic as well as superficial infection like dermatophytosis, deep mycosis, candidiasis. Mechanism of action, we already seen that they block this demethylase enzyme 14 alpha, which is responsible for synthesis of lanosterol, ergosterol from lanosterol. So it inhibits ergosterol synthesis and disrupt membrane function and increase permeability. Again, pharmacokinetically, it is effective orally, and oral ketoconazole tablets are available. Acidic environment favors its absorption, so antacids should not be used along with it. It is also having high plasma protein binding. Does not cross blood-brain barrier, metabolized in liver, excreted in bile. So it is safe in renal diseases. T-half is 8 to 10 hours, doses 200 mg once a day or twice a day. This is very, very important to remember. The adverse effect profile of ketoconazole, apart from GI upset like nausea, vomiting, anorexia, headache, paresthesia, alopecia can be seen. If you remember, headache is the most common side effect with glycopulbin, and alopecia you have seen already with 5-flu cytosine. Some hormonal interactions are there with ketoconazole. It will decrease the steroid, testosterone, ergosterol, estrogen synthesis. So it leads to gynecomastia, oligospermia, loss of libido, and impotence in males, while it leads to menstrual irregularities and amenorrhea in female. This is very, very common. This hormonal imbalance with ketoconazole is very evident and common. It also leads to elevation of liver enzymes, so it should use cautiously in patient having liver disease. And apart from that, some of the patient shows hypersensitivity reaction to ketoconazole, like skin rashes and itching. Drug interaction is also again, if you remember, 5-flucytosine and amphotericin B are synergist, while ketoconazole R and amphotericin B should not be used together. They are contraindicated. Why? Now you can see, as you all mentioned, that I asked you the question that amphotericin B is a ergosterol synthesis inhibitor. You said true, 60% of you, but it is not. While ketoconazole is ergosterol synthesis inhibitor, rather amphotericin B need ergosterol to act because it will bind to ergosterol only. So when you give it with other ergosterol synthesis inhibitor, the concentration of ergosterol will be less in the cell membrane, which will reduce the efficacy of amphotericin. So if you give ketoconazole with amphotericin, it might lead to increased toxicity of amphotericin with very less efficacy of it. So that's why it was a very tricky question. Amphotericin, we need ergosterol for its action. It is not a synthesis inhibitor of ergosterol. It needs ergosterol to act. That's why ketoconazole or other drugs which are ergosterol synthesis inhibitor are contraindicated with amphotericin B, especially ketoconazole. Now here you can see the drugs like cyclosporin, phenytoin, tolbutamide, warfarin. Their concentration increases when they are given with ketoconazole because ketoconazole is inhibitor of cytochrome P450, which by which these drugs get metabolized. So the metabolism stopped and their concentration increases will lead to the toxicity. Uses of ketoconazole, you see here, dermatophytosis, all the dermatophytosis infection you need to read. Monilial vaginitis, apart from oral amphotericin and nystatin, you can use ketoconazole. Rather, we use ketoconazole because of less toxicity relatively to the amphotericin and the cost also. Then comes systemic mycosis, where we can use oral ketoconazole or blastomycosis, histoplasmosis, coccidiomycosis. You can see the comparison between these infections, like it is less efficacious than amphotericin B for these infection treatment and slower response, and the decreased efficacy in immunocompromised and meningitis patient has been seen with ketoconazole, and lower toxicity than amphotericin B but higher than triazole. So ketoconazole in toxicity profile is coming in between amphotericin B and other triazole. So actually other triazole comes into the picture because of ketoconazole toxicity. So we want to make further changes in ketoconazole to produce a drug which is having further less side effects. So it is topically also used for treatment of teniasis infections, and it can be used as adjunct therapy in prostatic cancer. This is one of the anti-cancerous use of ketoconazole because of its action on the hormonal thing. So because it is it leads to reduce the hormonal content. It can be used for prostatic carcinoma in male because it is hormonal induced. Then comes fluconazole, very very commonly used. You can see the picture here that these kind of tablets are available, 100 mg tablets. This is newer advancement in azole group. So it is a newer water-soluble triazole, which can be given by all the possible routes like oral, intravenous, topical. So it is very useful drug. It is also having broad spectrum, but it is not effective against aspergillus and mucor. Apart from aspergillus and mucor, it is useful in almost all the fungal infection treatment, and it is well tolerable, and it is available in all the doses form. Bioavailability is very good, 94%, which is not affected by food and gastric pH. So the drug food interaction is less. Primarily, it excretes in urine. So there is some risk of nephrotoxicity, but very less as compared to amphotericin. Plasma protein binding is poor. Again, this will decreases the interaction of fluconazole with other drugs, and very widely distributed in blood-brain barrier. If you remember, another drug we read is flucytosine, which is crossing blood-brain barrier. So fluconazole is crossing blood-brain barrier, so it is good that uh, by its oral or parenteral route, it can be used for treatment of meningitis as well. Adverse effect, it is almost very very good drug, very tolerable. Apart from few GI upsets like nausea, vomiting, anorexia, abdominal pain, some other toxicity and adverse events like headache, alopecia, skin rash, hepatic necrosis can be seen. Teratogenic effect has been noticed, and hence it should not be given to the pregnant lady. They are having, they are also having enzyme inhibitory property like ketoconazole, but as compared to ketoconazole, less interaction, and there is no anti-androgenic and other endocrine effects. So all those side effects like gynecomastia and menstrual irregularities is not seen with fluconazole. But the advantage of that anti-androgenic effect of ketoconazole that it can be used as adjunct to the prostatic cancer. But rarely it is used there. Mostly we use it for treatment of fungal infection, and we need a drug which is having less interactions. So fluconazole is one of the drug here. You can see in treatment of candida, you can use a single 150 mg oral dose of fluconazole for treatment of vaginal candidiasis, and for oral candidiasis, we can give it for 2 weeks. In tinea infections, 150 mg weekly for 4 weeks. That is 4 tablets every week. But for onychomycosis, because the keratin is thick, 12 months treatment is required, which is further decreased with terbinafine. We will see that systemic fungal infection also, fluconazole can be used for disseminated candidiasis, cryptococcus, coccidial infections. Meningitis, it is preferred drug because it can cross blood-brain barrier. Other option is amphotericin flucytosine combination. Eye drop are also available for treatment of keratitis. Itraconazole is the broadest spectrum of all, and it is useful in treatment of aspergillus as well as histoplasma. It is a static drug. It also does not interfere with the hormones and hence less side effects. The bioavailability is good, 60%, but absorption is variable, and there is a lot of food drug interaction. Plasma protein binding is very very high. Apart from amphotericin, warfarin, remember itraconazole as well for their high plasma protein binding. Although all the antifungal agents are having high plasma protein binding, CNS penetration is poor, so in meningitis it is not useful, and it is metabolized in liver and excreted in feces, so there is some chances of hepatitis is there. This is important as far as itraconazole is concerned. Itraconazole uses. You can see here these special infections like paracoccidiomycosis, chromoblastomycosis, histoplasma blastomycosis. Here it is a drug of choice actually, superior to other antifungal agents. And as we see in chromoblastomycosis, it is combined with 5-flucytosine. Apart from that, it is also used for treatment of various candidiasis. In dermatophytosis, it is not superior to fluconazole, but it is useful. Onychomycosis, it is not superior to terbinafine, but it is useful. Aspergillosis is one of the advantage of itraconazole is the treatment of aspergillosis. And adverse event you can see is GI intolerance, like similar to the other antifungal agents. Dizziness, pruritus, headache, and hypokalemia is something peculiar about itraconazole. It is very, very rarely, but hepatotoxic as it is metabolized in liver. There are some drug interactions like oral absorption reduced by antacid and S2 blocker, just like ketoconazole. Rifampicin phenytoin induce the metabolism of itraconazole, and it inhibits the this enzyme cytochrome P3A4. So the profile is similar to ketoconazole. So actually, these group of drugs, which we can say azoles, they are inhibitor of cytochrome P3A4. So there is some interaction, but least with fluconazole and maximum with ketoconazole. Then come voriconazole, which is a second generation triazole, and it is having high oral bioavailability and low plasma protein binding, and both these things are welcome response. Good CSF penetration so can be used in treatment of meningitis, metabolized by cytochrome P2C19, not by CYP2 3A4. So because it is metabolized by cytochrome P2C19, the inducer and inhibitor of this enzyme interact with voriconazole in different ways. Doesn't require gastric acidity for absorption. So with antacid, there is no much issue. And you can see it is given by parenterally, and you can see this vial containing 200 mg of voriconazole for IV injection infusion only. So we need to reconstitute it. It is in dry powder form. We need to reconstitute it by making it liquid preparation. Drug of choice for invasive aspergillosis. You can see aspergillosis is not very easily treatable. Amphotericin B was the one drug because amphotericin B is the broadest spectrum useful in all the fungal infections. Apart from that, for aspergillosis, you have very less option like itraconazole, voriconazole, and for mucor also you have very less option like posaconazole. Most useful for esophageal candidiasis, first line for molds like fusarium, and useful in resistant candida infection. Voriconazole can be used in candida infection which are resistant to other drugs like fluconazole, ketoconazole. The dose is 100 mg, and a good thing, a peculiar side effect like hypokalemia with itraconazole, you need to remember visual changes with voriconazole, V for voriconazole, V for visual changes. This is how you can remember it. So some transient visual changes like blurred vision, altered color perception, and photophagia can be seen. Rashes in very less percentage, elevated liver enzyme rarely, and prolongation of QT is rarely seen. So prolonged QT prolongation, a drug which can lead to QT prolongation, you need to have a list separately. Make a list of drugs that can be, uh, you know, cause QT prolongation like bedaquiline. There in ATT we read and deplominate. Then here it comes like posaconazole, voriconazole. Then posaconazole is not written here, but just remember that posaconazole is the latest entry in triazole group, which is useful in treatment of mucormycosis. Then comes to another group of ergosterol biosynthesis inhibitor, terbinafine, as I already told you, that they are synthesis inhibitor, not amphotericin. Orally and topically, terbinafine is effective, and now it is very, very useful and commonly used drug because it reduces the course of therapy. ये जो भी हम देख रहे थे 6 month therapy, 12 month therapy is reduced to weeks because of terbinafine. And also the relapse rates has been seen to be decreased with terbinafine. So pharmacokinetic of terbinafine here is it is very well absorbed, a good bioavailability of 75%, highly keratophilic, that is keratinized tissue mein iska concentration is good, where we need to use it, and good lipophilicity, so the penetration is good, it reaches to the tissue properly. Plasma protein binding is high, so the drug interaction will be there. Poor blood brain barrier permeability, so cannot be used in meningitis. T half is 15 days, negligible effect on cytochrome P450, which is a welcome thing because the drug interaction will be reduced. So now comes the mechanism of action here, you can see the enzyme squalene epoxidase, which is converting squalene to squalene epoxide. And then this squalene epoxide is converted to lanestrol. And then lanestrol is converted to ergosterol by 14 alpha demethylase, where this is the step where azoles were acting. This is the step where terbinafine is acting. So terbinafine and azole group are the two group of drug which are ergosterol synthesis inhibitor. Amphotericin is not a ergosterol synthesis inhibitor. Rather, it needs ergosterol to bind to its target and act. So you can see adverse event and uses of terbinafine, like adverse event very less, like nausea, vomiting, diarrhea. Taste disturbance, like you remember voriconazole, V for voriconazole, V for visual disturbance. Similarly, you need to remember terbinafine, T for terbinafine, and T for taste. Uh, okay, so you are saying that terbinafine is lipophilic. Still, it does not cross blood-brain barrier. Yes, it can happen. It's not necessary that every lipophilic drug can cross blood-brain barrier, because it is not the only factor which is responsible for crossing some barriers, because the size of the drug is also matters. Permeability also matters. So because of the size of the drug, which is uh, prohibiting it to cross blood-brain barrier. So lipophilicity is one thing which is required. So like if you talk about blood-brain barrier, if we talk about glomerulus, their size of drug is important. In blood-brain barrier, lipophilicity is important. As you say right correctly that terbinafine is lipophilic, it should cross blood-brain barrier, but still because of some factors to treat meningitis has not been achieved, and hence it is not useful in those conditions. So yes, it is a very good question, because you are understanding the concept. That's why you are asking. That is very good question. A drug which is lipophilic and not crossing blood-brain barrier. The question was correct. But yes, there are multiple factors that can prohibit a drug to cross blood-brain barrier, not only the lipophilicity. Uh, so to continue it, as I said, if you are remembering the visual disturbance with boriconazole, just remember taste disturbance with uh, terbinafine, and it is rarely causing hepatic dysfunction, less drug interaction, and hence very well tolerable drug, and hence we are using it nowadays. And the good thing is about terbinafine is oral tablet as well as topical ointments are available. So topically, the side effect can be seen as erythema, itching, dryness, and urticaria. These all are actually the side effect of root, not the drug. If you see the uses of terbinafine, here dermatophytosis, onychomycosis, candidiasis. You can see the main thing about terbinafine treatment is that the course of therapy is decreased. So for dermatophytosis now 2 to 6 weeks of treatment is required with terbinafine, which was in months for with other antifungal agents. Onychomycosis 6 month treatment was required by azole group. 6 to 12 weeks is there with terbinafine, and 6 to 12 weeks means for fingernail 6 weeks, or toenail 12 weeks, like that. Then candidiasis is less effective. It is less effective. Azole group is more effective, but 2 to 4 week therapy may be required with the dose of 250 mg. Then comes this group, echinocandin group, where the drug is caspofungin is there. This echinofundin groups are inhibitor of beta 13 D glucan synthase enzyme, which is responsible for synthesis of beta 13 and 16 glucan, so that there is a cross linking and providing support to the cell wall. So it is useful in invasive aspergillosis and candidiasis. So apart from amphotericin, itraconazole, voriconazole, caspofungin is the fourth drug which is used for treatment of aspergillosis. It interacts with cyclosporin, causes hepatotoxicity, and it increases the clearance of tacrolimus. So these are two interactions seen with caspofungin. It is given by parental route only and not very commonly used. Adverse event with caspofungins are like flushing, rashes, nausea, vomiting, phlebitis. This is the reason where echinocandins are useful. I told you this the site of action is this beta 1,3-D glucan synthase enzyme, which is ultimately responsible for synthesis of beta 1,3-glucan and 1,6-glucan, which provides support to the cell wall. Now the last two slides, last four slides actually, 4 slides, and we are done. So topical agents used in dermatophytosis are tolnaftate. You can see these preparation in various ointments. So it can be used for treatment of tinea cruris and tinea corporis along with the systemic drugs. We can use these topical agents in adjunct to those systemic treatment. So 1 to 3 weeks of treatment is required. It is not effective in hyperkeratinized lesion because the entry and the penetration is also less. So sometimes we use some agents like salicylic acid, which by its keratolytic property uh, facilitate the entry of antifungal agents in hyperkeratinized lesions. So this combination of salicylic acid with antifungal agent is there. So this is another question: what is the rationale of combining salicylic acid with other drugs? So salicylic acid is a keratolytic agent. It is always improve the penetration of that drug into the tissue. That's why salicylic is used. Remember, agents available as ointment and cream, which is useful in tinea infections and candidiasis, can be used topically. It penetrates superficial layer and useful in teniasis and candidiasis. And it acts by inhibiting membrane uptake of precursor of macromolecule needed for fungal growth. This is a simple single line mechanism of action which is known so far for cyclopyroxalulamine, is that it acts by inhibiting the membrane uptake of precursors of macromolecule which is needed by the needed for fungal growth. So they are static in nature. Then anticyclinic acid 5% is useful. It is combined with zinc. So it has high relapse rate, require prolonged treatment, and it is weaker antifungal agent used in treatment of tinea cruris and nappy rash. So there are many ointments and cream available in market for pediatric population. Nappy rash is a very common rash, happen because of the wearing wet nappies for whole night and whole day by the kids. So to treat that specifically, anticyclinic acid with zinc combination is used. Sodium thiosulfate is another reducing agent. It is also known as hypo, and it is effective in thyrosis versicolor. Then benzoic acid is very commonly used topical anti-fungal agent, which is combined with salicylic acid. The rationale I already told you, because it is keratolytic agent. Salicylic acid, it removes the infected tissue and helps penetration of benzoic acid in fungal infected lesion. This is the rationale of combination of benzoic acid and salicylic acid. This is very uh, commonly asked question, and the combination is known as Whitfield ointment. That 6% benzoic acid and 3% salicylic acid, and the rationale I already told you. Adverse event is same, burning and irritation, and ring cutter ointment is also benzoic acid containing ointment. So here comes the summary of whatever we read so far. So there are drugs which are used for systemic administration as well as topical. There are drugs which are useful in both, like amphotericin. It is available in topical form as well as systemic form, parenteral, oral. So it can be used systemic and superficial fungal infection for both. So if you are giving systemic administration of amphotericin, can be useful in treatment of systemic as well as superficial fungal infection. Ketoconazole is again available in both the form, systemic as well as topical. It its systemic administration is also helpful in targeting both systemic and superficial fungal infection. Then other group like triazole group may you see fluconazole, voriconazole, itraconazole, they are only available systemic. Fluconazole का कोई topical preparation available नहीं है. So if you want to give fluconazole by oral route and if you want to support it topically, you need to use some ketoconazole ointment or this miconazole, oxyconazole, niconazole ointment. So just remember, triazoles may only terconazole is one drug which is topically available. Otherwise, all rest of the triazoles are not topically available. Guisophulvin is the systemic drug for superficial fungal infection. Similarly, clotrimazole is one of the imidazole which is not available for systemic administration. It is available for topical only. Terbinafine is available in both the forms for systemic administration, oral tablet, and for topical cream ointment. But it is very important to understand that both griseofulvin and terbinafine, whether you are giving terbinafine by oral route or by topical route, it is only useful for superficial fungal infection. It is not useful in systemic fungal infection. Again, the same thing which uh, one of your colleague asked, that being lipophilic, it should penetrate to various tissue. Yes, but the concentration required for treatment of that and the efficacy of the drug is not very good. So it is useful in treatment of superficial fungal infection, whether you are giving by oral route or topical. Guisophulvin is not available topically, so it is given orally only, but useful only in superficial fungal infection, not in systemic fungal infection. Echinocandins can be used in systemic fungal infection and available in systemic administration parenteral route. Nystatin is similar to amphotericin B, but only available by topical route. 5-flucytosine is available orally, very good bioavailability, combined with amphotericin B for treatment of cryptococcal meningitis, and it combined with itraconazole for treatment of chromoblastomycosis. Now you can see the spectrum of action where amphotericin is a broadest spectrum, which is useful in treatment of all the available funguses like Aspergillus, Blasto, Crypto, Coccidio, जितनी भी हैं सब मेन्यू पर Aspergillus. While if you see 5-flucytosine only useful in cryptococcus meningitis with amphotericin B and chromoblastomycosis with itraconazole, and in candidiasis में all the drugs are effective. Ketoconazole not for Aspergillus and cryptococcus, no use in mucor, but only dermatophytes. Apart from that, Blasto, Coccidio, Candida, Histoplasma. Fluconazole, almost all of the fungal, but not Aspergillus and mucor. Itraconazole is covering Aspergillus, but not the mucor. So for mucor, the drug other than amphotericin is posaconazole. So this is all about antifungal agents. So we finished it in 1 hour 40 minutes. So it's okay. If you have any doubt, you can ask. With that, I am finishing my antifungal topic.